Hey everybody, welcome back to this week's Synapse Care Solutions live stream. And I am excited. Today is part 1 of 4 that we are going to be releasing to you this month, August 2023, on what is a NeuroNICU. It is our 4-pillar framework for creating, assessing, and improving the NeuroNICU practices that you might want to do. So in this series, we are going to walk you step by step. Week 1, we're going to talk about the what, the why, and the how of creating a NeuroNICU. And then we're going to dive into pillar number 1, which is neuro-assessment. In the following weeks, we are going to go into neuromonitoring, we're going to go into neuroprotection, and neurodevelopment. So follow along for each week, and we will add these all together. The other bonus for August is that you can also get free contact hours, nursing contact hours, and CEU credit for watching these videos. So all you need to do is either scan the QR code on your screen or click the show notes below, and you can actually get CEU credits this month. So it's really exciting that we're able to offer those for you. When we work with people all over the world, we find that it's oftentimes overwhelming to get started with a NeuroNICU program, and they just don't know what that means. So with this 4-pillar framework and some of the other tools and tips that I give you, and a workbook. So if you want the workbook, go ahead and again, click the show notes below, or go ahead and scan the QR code that's on the screen. And this workbook will also help you to take notes as we're going through, but also to give you an idea of where you are and where you want to go. So in working in the NICU, we always want to make improvement, process improvement, quality improvement, practice improvement, implement research findings. There's so much that we can do, but it can be overwhelming. So I hope that this conversation this month helps to dial that in for you, gives you a framework in which you can make change. Again, I hope you enjoy week 1, where we will dive into the what, why, and how of a NeuroNICU, as well as the first pillar, neuro assessment. So from here, take it away to our workshop that we recorded back in 2018.
We're going to dive into this concept of every NICU is a NeuroNICU. And this is a kind of a reformat of the pre-conference that we did at NAND. And we had about 140 nurses from all over the US and Canada with us there as well. And just thought maybe this was an opportunity to offer this presentation to a wider audience and just let everybody from really anywhere in the world join us. I think that this is such an important topic, but I think it's also a very important nurse-driven topic. And I know that many NeuroNICUs are really led out by neonatologists and neurologists, but I think that the nurses obviously play a very important part in creation of a NeuroNICU, as well as the ongoing sustainability of those programs. And I appreciate you all being here. And so I'm assuming just from the names, I know that most of you are nurses, so welcome to all of you for being here. So let's dive into the content a little so that we can get started. So when I did this presentation at NAN, it was 4 hours nonstop. I think maybe we took a 5-minute break. And so with the luxury of being online, I decided to spread this presentation into parts, and also to allow us to dive a little bit deeper, ask questions, and do some of the things that maybe we didn't get to do when we were together in Providence, just because the time didn't allow it. And certainly if you attended in Providence, we really did feel like we could have stayed there all day. Honestly, it was really fun in the networking that we did. So I'm glad to be able to do more of it here online. So just a little bit about me. My name's Kathy Randall. If we haven't met before, I'm so happy to have you with us and to be a part of your day today. I wear several different hats depending on the day of the week and where I am in the world, but I like to just call myself a freelance clinical nurse specialist. I've been working in the NICU for over 20 years and have been an educator for many of those years, clinical nurse specialist, nurse practitioner, and really for the last decade have spent my career traveling around to different NICUs, helping them to integrate either brain injury prevention programs, improving developmental care, hypothermia programs, and brain monitoring. And so those are really the backbone of a NeuroNICU. And as the concept of NeuroNICU has come to be, I've become a consultant at different NeuroNICUs around the United States as well as internationally as well. So I've had the opportunity to travel to the Middle East to help with NeuroNICUs that are opening in that part of the region. Throughout Asia, I have traveled to China and to Thailand to help there, and have traveled to Brazil, have done some remote work for some units in Brazil, and going back next year to help solidify some of the training there as well. So NeuroNICU is really taking off across the globe, and everyone is looking for improving outcomes for babies. And I think that's the most important thing that all of us want to do every day in our day-to-day work. So just to give an overview, just like I said, I've divided this into parts and really want to take a deep dive today into kind of what is this NeuroNICU, why this trend of NeuroNICU is taking off around the globe, how to really make changes in your NICU, and how to maybe pick apart the programs that you already have. We're going to talk specifically today about neuroassessment. So I love to find out who is on the call, and tell me how many years you've been a NICU nurse. This is always one of my favorite questions to ask. Jane's been a nurse for more than 30, Shelly more than 30, Sharon 18. It's amazing. Sarah 6. Hey Sarah. Katie 12. From the business 15 or more. They're not saying. It's probably a good thing. Anybody else? What I love about this is that what we realize, so you've got Kim is 26 years, Heather's an OT that's with her 19 years. This is fantastic. What I love is that we've all have different experiences. We come from different units. We've done different things. We've had different roles, wore different hats. Maybe we never wore a hat quite like in this picture, but we all are still here because we're wanting to improve and learn more and more about what it is to be a NeuroNICU, how we can take care of babies and their developing brains even better. And so I love this. And when we did the presentation in Providence, we had some nurses in the audience who had actually been NICU nurses for more than 40 years. And I think that is amazing. And I love that you are here and that you've dedicated this time to learning more about the baby brain. So let's move forward here. So just to give a rough outline, we want to really break down this presentation into the whys, the whats, and the hows. So I love sharing information, but it doesn't really matter to me how much I teach if it's not applicable or something that you can go back to your unit, start a conversation with someone, and maybe do something different. And so that's really why I love to teach, is that I want it to actually change something. I don't want it to just be new knowledge that sits there. I don't want it to be new knowledge that you don't share. I want it to be information that we do something different. So first off, we'll talk about why. So this trend of the NeuroNICU. Then we're going to talk about what are NeuroNICUs, what are their kind of focuses of care, what are some bedside things that we can do, and then the how. So of course, we know that any kind of change that happens in the NICU is not done by a single person. It always takes a partnership amongst a number of people. And nurses are, of course, very important in that. And we want to make sure that by the end of all of this information that you actually have an idea of one thing that you might go back to your unit and do differently. And so there are some people on this call who I know have attended previous either conferences or workshops that I've done and have stayed in touch with me and have shared with me things that they have done. And I hope that we might have time to hear from some of them as well. So let's just dive in then to the why this NeuroNICU. Number one, I think it's important to just realize that we have had for the last several decades had increased survival, but that we have also seen increased morbidities with that, and that we are not making a huge impact on reversing some of this trend. And so when we think about neonatal brain and brain injuries, there are, of course, a number of causes for brain injury. And of course, we're not going to get into the pathophysiology of those, although next time we'll talk a little bit about HIE specifically and some of the treatments that we offer that. But really, the causes of brain injury are numerous, and many of them still unknown. And what we do know for sure is that the outcomes for our babies are very much dependent on the location of this injury, the timing of this injury, the extent of injury, and any interventions that are possible, and the timing of these interventions. So even for something as quote unquote routine as post-hemorrhagic hydrocephalus, if we don't intervene at the right time for that, we can have devastating consequences to that baby. So when do we shunt? When do we not shunt? When do we tap? Do we tap? Do we put a reservoir? I was just at a meeting in Boston last week where we were talking about standardizing care around post-hemorrhagic hydrocephalus. This is what NeuroNICUs can do. They can look at a simple complication and they can change practice. So interventions need to be provided at the right time when it comes to brain injury. And next time we'll talk a little bit more about neurodevelopment and really these critical periods of brain development and why it's so important that we intervene at the right time. So again, the incidence of neurological disabilities related to perinatal brain injury has not really decreased in decades. This is something where it's a very well-known fact. We know that there's a range of injuries, things like CP or cognitive impairments, things like epilepsy, seizure disorders, and both term and preterms can be affected. And maybe the preterm being more susceptible due to some developmental changes. I love to share this. I guess I don't really love the data, but I love to share it because I think it really does definitely bring home the point. When we look at mortality and morbidity among survivors, and I'm actually going to show you an update of this that was published in 2015. So when we look at mortality and major morbidities among survivors, so we want to think about why this NeuroNICU idea is coming out. And so what I wanted to just show you, these are groups of babies divided by size. So 500 grammars, 750 grammars, 1,000 grammars, 1,200. The red bars are the babies who died in these different groups. So born between 500 and 750. These are in two different, almost a decade apart, 2000, 2009. You'll see that the babies that died were about, in the small group, were about 40%. So a little bit less than 40 in 2009, so small improvement. And so that's what we know, right? Almost a 50-50 chance of survival. Then we have this blue bar. This blue bar actually shows the number of babies who survived, but who had one or more morbidity. So these are things like IVH, PVL, BPD, ROP, all the alphabet soup of things that we talk about when it comes to complications related to being born premature. Then we have the space between the blue bar and the 100%. So in this case, it's right about 10%. And then of course, between 2000 and 2009, very small improvement, not statistically significant improvement, but about 10% of babies who leave the unit without one of these morbidities that we commonly associate with being born premature and being in the NICU. Then you see as we get bigger, the 750 grammars, fewer die, fewer leave with, or more actually leave with a disability, and then, or morbidity. And then we have this space here between leaving with one morbidity and no morbidities, that those lucky few, right? These are those lucky few in here. And so what we see is that this number gets bigger and bigger, the ones who leave the NICU without any issues, improving until we get down here to about 20%. So the smaller you are, the more risks you have. And so I think we all can acknowledge this. So what about some updated outcomes? And so I mentioned that in 2015, Dr. Stoll published his cohort, and looking again at the Vaughan registry. So this was from 1993 to 2012, almost 35,000 babies aged between 22 and 28 weeks at 26 of the neonatal research centers. And what we found, and remember the last data I showed was till 2009, that survival is improving. So survival is increasing for babies who are greater than 23 weeks. So this means that the ones that are 22 weeks are not so well. Reduction in intracranial hemorrhage for the 26 to 28 weekers. We did see a reduction, but not for the smaller babies, not for the 22 to 25 weekers. Although we did see increases in steroid use from 24% to 87%, so this maternal antenatal steroids, and intubation at delivery decreasing from 80% to 65%, so more non-invasive. So we are seeing some changes in practice. We are implementing these things, but we're still not seeing a huge reduction. And so I blew up some of the other little slides that went along with this article. This article is filled with statistics. So if you love statistics, this is a great thing for you to go check out. So I'm going to blow up a few of these slides a little bit more. So we can see the 22 weekers, and we want to take this with a grain of salt because there were actually only 5 babies that survived in this cohort. But we can see that the percentage of babies with severe IVH kind of increased and then has decreased, but really not making any changes there. We see here for 23 weekers around 40%, and now we've dipped down just under 40%. And this is the confidence interval here, and then the actual numbers are the little red circles. So the actual number, we actually see a shift back up, but the trend is downward overall. 24 weekers, we can see the overall trend is going down a little tiny bit. And then here, a little tiny bit for our 25 weekers, 26 weekers, 27 weekers, and 28 weekers. Definitely we can see a trend down towards a reduction. So what does this all really mean? Survival without major morbidity increased by approximately 2% per year for infants between 25 and 28 weeks, and no changes for infants between 22 and 24. We are making some improvement, so a 2% decrease per year, but we are still far from making drastic changes. So this is still an area of huge concern. So I love this letter that Dr. Levine wrote back in 1981 to the editor. She wrote, on the basis of our follow-up data, we feel that the size of the hemorrhage on ultrasounds is by no means the only guideline to outcome. So what is she saying when she says this? This was 1981, so if you can imagine how high resolution ultrasound was. But even at this time, we really already had the Papille grading system for IVH. And so she was looking at preemies. She did an amazing job of doing tons of follow-up. And we were talking about what was the thing that they were trying to figure out was guiding outcome. And what she was realizing is as much as emphasis as we put on the size of the hemorrhage, she realized it was by no means the only guide to outcome, and that there may well be other factors influencing the results of this neurodevelopmental outcome that we cannot yet diagnose by ultrasound. So now here we are 30-ish years later, and we're seeing more and more uses for other kinds of imaging, which we'll talk about, but we really do still focus a lot on the IVH. But there's really more to the story than just IVH. So I'd like to share some of these outcome data. This is from the Epicure data from the UK. And so we're looking at this cohort of small babies and looking at their IQ scores at 26 years of age. And so here we see the red line is our preemies, the blue line are the controls, and we see that even at 26 years of age, that preemies have a lower IQ score. We look at verbal IQ, we see that again, preemies score lower. Performance, preemies score lower at 26 years of age. One of the scariest things I think that many of us have learned about in the last decade is really this prevalence of psych disorders. So this is looking at preemies, a group again from the UK Epicure study, 219 extremely preterm babies, less than 26 weeks. They're indicated by blue lines here on this graph. And we're looking and seeing at the prevalence of psych disorders at 11 years. So again, this is not a short-term outcome, this is a long-term outcome. And so we see that if we look here, we see the blue bar. For any kind of psych disorder, we see that the blue bar is very high, almost like 23%. We see for the red bar here, almost 50% less, only more than 50% less, right? 8%. And if we look and say, okay, those all psych disorders bunched together, well, what about some of the other more specific things like ADHD? So we see, again, preemies have a higher prevalence. Conduct disorders, we see little term babies have a little bit more. Emotional disorders, preemies, and then ASD or autistic spectrum disorders, we see preemies. We see them having a completely 8% here, and having almost 0% for the term equivalents. So what we know is that there's something more, because we know that these are not things that are caused by IVH. There's something else going on that makes our preemies different. So I like this frequency distribution of autism spectrum disorder. So breaking this down a little bit more, and it's a really busy slide, but here is the threshold for autistic spectrum disorder. and then the threshold for autism. And we see these are the total scores, number of children who had these scores. So the higher the score, the more likely you are to have autism-like behaviors. And we see the green bars are the preterms and the yellow are terms. And we can see that the yellows are quite high for the score over here. We have a lot of kids who have kind of some, one or two odd things, but when you put them all together, we see that it's the preemies and these green bars that really over time have the highest number and perpetuate out over here to even having a score of 30 and 35. So the odds ratio in this cohort was showing that preterm babies were 6 times more likely to have autistic spectrum behavior disorders or to be diagnosed with autism. So what is it that is causing these sensory overloads, these communication things, these social dysfunction? These things we don't quite understand why, but we know that there must be something special about what's happening to babies in the NICU that puts them at risk for this. So in 2010, Dr. Milgram said, neither the structural brain alterations nor the medical complications common in the NICU fully explain the variation in long-term neurobehavioral development. So what we think that we know why these babies are different, it doesn't really explain it, right? So neither the structural brain alterations, things we can see with ultrasound, things that we can see with MRI, things like IVH and PVL, nor the medical complications. So IVH, BPD, ROP, all these things together don't fully explain the variation in long-term outcome. So there is something more that we are not yet fully understanding. Looks like there's a little chat here. So Jane is saying migrational issues from germinal matrix and pain. Absolutely, Jane. So these are definitely things, right? So we know that as the neurons are developing and wiring and firing together, there is something else going on. Something else is happening that doesn't quite explain why these connective problems are happening, these synaptic problems. Absolutely. So there's something far more. So first off, why is there a trend where we know that there are these increased morbidities, whether or not they're physical morbidities, emotional morbidities, we know that there's these morbidities and that we're doing better with survival, but we're actually not really improving these morbidities. More than 2%, right? So we all acknowledge 2%. The other thing is that there are a lot of local experts in your hospital. And so NeuroNICUs really take what you're already doing and put them in a framework and help for us to be able to care for our babies in a more organized way and take advantage of all of these specialties. And so there's a big group that we want to bring together. And that's one of the kind of funnest parts of the NeuroNICU is bringing all these groups together. The other thing we want to do is bring new care practices and research findings to the bedside. So it's not enough that these research groups do all this work, but that if it comes and trickles its way actually to the bedside and changes the way that we actually provide care, what's the point of all this research? What's the point to just describe what's happening if we don't actually look for ways to make things better? And so that's when I was talking about in the beginning is it's not enough to just talk about all these things, right? We want to actually do something about it and take your specific unit's needs and then tweak something that's of importance to you and to your local team. And then last but not least, this trend of the NeuroNICU is really all about improving outcomes. And whether that's improving bonding or decreasing the amount of children that have sensory issues or dropping ROP, it doesn't really matter what it is, but really to improve anything in the short term and the long term to really help these families and to help these babies. So that was all the why, and I'm sure that all of you who are on this webinar are very acquainted with the whys of why we want to do these things. And so now let's break it down into the whats. What are these NeuroNICUs doing and what can you do in your unit? So I'd like to say, isn't every NICU a NeuroNICU? Because every NICU has babies that have developing brains in them. Even a full-term newborn is still has a very immature brain, right? That's why they need to be held and rocked and they don't walk for over a year, right? These babies are still developing. Even healthy full-term babies are. But if a baby finds themselves in a NICU, then their brain is at risk. And so when you think about what a NeuroNICU can be in your unit, it could be a simple QI project. Maybe it can be something as simple as We want to improve the use of sucrose in our unit. We believe pain is bad. We believe that we can utilize sucrose more efficiently and effectively, and according to our protocols. We're not going to just dose every single baby who squawks. We're not going to just give them that, but we're going to make sure we give it 2 minutes before and blah, blah, blah. So a QI project is addressing pain. You could address a pain. You could say, we want our families to have more kangaroo care in the first 2 weeks of life. So how can we do this in our unit? So a neuro-NICU is really every NICU. And as long as you're taking a focus at practices that improve the brain, it can be something as simple as that. You can take a program you're already doing. So the kangaroo care is probably a good example because every hospital, every NICU offers kangaroo care. But maybe you can get a little more systematic about it. Maybe you can measure some of the things that you're doing. Maybe you can actually put in your medical record how many minutes of kangaroo care your babies are getting and measure that dose over the first 2 weeks of life. So just things like that. So you can do a QI project and try to improve one thing. You can expand a program. You could actually take advantage of designing a new unit or changing something in your environment to make it more appealing for families or to provide a better balance of noise and meaningful sound. Or maybe it's just a change in culture. So maybe it's that you need to do some work on people's attitudes around developmental care or around kangaroo care. And so these can be also a neuro-NICU as well. So I like to break things into a framework, and I didn't put education on here because I always feel like everything always turns out to be education is necessary. So some education is needed, but I think in the framework of thinking about the NICU and the things that we do, and when we're making a change in practice or changing a program, these are the different areas that we want to look at. So we want to look at our baseline practice. How are we doing? What are we doing? And how can we maybe do better? We always want to think about, do we have the right personnel? So do we have enough staff? Do we have enough of the right kind of trained staff? Do we need to hire some different staff? Do we need help? Do we need support? Are we doing research? Is there a quality improvement opportunity for us? Or is it equipment? Am I missing equipment? Do I need to buy some equipment? Or is our equipment malfunctioning? And so we offered this survey out for Providence. We wanted to ask, where did some of these things fall? And so here's some of the things that you guys said. So when it comes to practice related to developmental care and to providing neuroprotective care in your units, these are the things you said. You said that right now you're having no consensus. People are not doing the same things. You lack provider approval. You lack staff acceptance of developmental care, and inconsistencies. This came up a lot. Inconsistencies in care. Really wanting to get people to do things in a very similar way. No compliance with midline head positioning policy, which we'll talk about next time. And then this was another one that we'll talk about next time, which is getting babies to the cooling center on time. So really, again, giving those therapies within the right times. So what are some of the things that you're struggling with in your unit? What are the things that are not as consistent as you'd like them to be? So go ahead and chat in. Let's talk about a few of these. So what other things? Positioning inconsistency. Yeah, that's a big one, Sharon. So do they have the right tools, but they're not using them? Or is it an equipment issue? The preemie flip. Yes, the preemie flip. So for those who don't know what the preemie flip, we'll talk a little bit about it next time, but that's a huge sensory overload. Pain control. Sharon also mentioned pain control. Lack of containment during cares. Less kangaroo care once the baby comes out of the isolette. That's a good one, Sharon. Disruption in sleep. Time-driven rather than infant-driven care. Sarah, I love that. Yeah, so what can we do about these things? What can we do to change practice? No buy-in for kangaroo care at all. Oh, Kim, we all feel your pain. So Sharon's saying we have all of the above. So you mean we have all of the above, all of these problems? Sharon, you have all these same problems? Yeah, these are very common. Yeah. More family education. Yes. On the importance of a therapeutic environment. Yes. We need these things. And families sometimes emulate what they see staff doing. So if they don't see role models in the unit, or they don't see an emphasis on this, they might just be doing what they see. Hospital buy-in. Ooh, that's an interesting one. Handling babies among various disciplines. So minimal handling protocols. Yeah. No, these are all so important. It's awesome. Yeah, and so these are all possible things that you can handle as part of your NeuroNICU program, right? So if it's minimal handling, right? So even if we just took that and broke that down, that could take a whole year to tackle, right? By the time we educate some people, create some signs, maybe monitor this, figure out what's happening. These are just simple things that can take time, but we need to have invested people to do them. All right, let's see what else other things you said. So some of the things that you just mentioned, which I think probably all of you will agree with too. So other challenges that some of you who are either watching the recording or who couldn't be with us today said were how to decrease stimulation for sick babies. So that environment, so I think we mentioned that. How do you provide cycle lighting? We think that this might be a good idea. How do we do this? Somebody mentioned teaching parents, so communication, right? How do we teach people who are in stress and strain? Poor communication from OTPT, but I think that could be really poor communication between disciplines. So whether it's physicians to nurses or nurses to therapists or physicians to therapists to rehab to follow up, right? Communication between disciplines, making sure that we're all on the same page. This is really challenging. We work different days, we work different times. Maybe we don't see each other, maybe we miss a meeting. So these are all things that are really challenging. And then skills. So there's some lack of skill, right? So low experience on transport teams, transporting HIE babies and preemies. So probably providing hypothermia during transport, and how to read aEEG. Personnel. So what about in your units? What are some of the things that are going on with personnel when it comes to implementing new practices? So some of the things that you guys mentioned: busy units, no developmental team, no staff buy-in, lack of funding, no OTs and PTs. So the places that have OTs and PTs are complaining that the actual communication is bad. Some places don't even have OTs, lack of acceptance, staff culture, and busy units. So what are some of the issues that you guys are seeing? Do these resonate with you guys? Are you guys feeling the same way? So you can either do thumbs up or you can chat. Staff turnover. Yeah, staff turnover. How about retirement? Some places retirement. Some places all of our champions are retiring. So it is really a struggle. And I think as we do see this mass exodus over the next 10 years of our baby boomer nurses, staff turnover, that's a big one, Kim. Floats who have knowledge of care. So yeah, do we have a floating program? Do we have an actual training program for them? These are great. These are really important. Yeah, these are really good. All right, so let's see what else we have. So we have, remember, these other things. So equipment, so things that you guys said that you needed. Good lighting for exams, lack of funding. So there's equipment that you need, but you don't have the funding. Not enough positioning aids. So Sharon mentioned that. Crowded spaces, equipment that malfunctions, that never happens, right? We always have perfectly working things. So so going back to the personnel, so Sharon's saying, starting to have experience turnover. So younger, eager nurses that need lots of opportunity, yeah, but also need lots of training. This is a huge strain, the things we want to do versus the things we can do. Really good point. Yeah, I like that, experience turnover. It's not just staff turnover, right? It's just not just the young ones who are getting a little bit of experience in your unit and then going somewhere for more money. This is true experience turnover. I don't know if you coined that term. Yeah, Katie's saying same for you guys, experience. And so what are we going to do about this? How are we going to train these next group of nurses and make sure that they're getting what they need and making sure that the babies get what they need? So equipment is a huge issue. One of the things that you guys didn't say was we need more drills. Oh, I love this idea of drills. Yes, we need more drills. Yeah, I think this hands-on simulation, really helpful. For hypothermia, I think it's really helpful. I think for even kangaroos, everyone's agreeing yes to drills. So we definitely, I think, taking this simulation knowledge that we have from megacodes and NRP and really translating that to other opportunities. We did a skills day a few years back where we actually did the standing transfer as a drill, where we brought in the babies and brought in the incubators and just trying to get people more comfortable with a high acuity baby, getting them out of the bed and how to do that more smoothly. And so doing the drills. So Sharon says they're planning that. Yeah, I think it's really important. So one of, I think, the biggest issues with equipment is storage. So definitely storage for all this equipment that we need. And these NeuroNICUs have a lot of equipment, right? They are crazy types of equipment. So we have got new monitors and more monitors and all of that. So yeah, storage is crazy, right? We almost pray for there to be a lower census so we can use one of those bed spaces to put all of our stuff. All right, so these are some of the challenges, right? So just so that we make sure that we know that you're not alone, I wanna make sure that you know that these are common problems and that you're really surrounded by a group of people who are also experiencing similar challenges and who have lots of awesome ideas for success as well. And so we wanna make sure that part of these programs that we offer are also an opportunity to network, for you guys to share email addresses and policies and other things like that. It's just not enough for each of us to have to do these things on our own. I'm all about networking. I'm all about having people get information so that they can do all these great things, but in the quickest amount of time, right? So we don't need to all reinvent the wheel. All right, so let's dive in then to these 4 pillars of neuro-nurturing NICU care. And so again, these neuro-NICUs, these neuro-ICUs or neurocritical care units, they're popping up all over. And for me, I really feel like the type of care they're focused on fall into these 4 pillars or 4 buckets, however you like to look at it. So first off is neuro-assessment, which we're going to spend time talking about today, and then neuromonitoring. And then next week, we'll talk about neuroprotection and neurodevelopment, which is a lot of the stuff that we've been talking about already. So let's just dive in then to how we assess the brain. And this can be quite a complicated way of doing it. There are many complicated ways of doing it. And I think that there are many challenges to the way that we assess the brain as well. So some of the things that you mentioned in the survey were challenges to assessment, was really how do you provide age-appropriate care? So how do we even assess what is age appropriate? And then these older babies, if you come from a children's hospital, you have older babies in your units too. So this cue-based care, this infant-driven feeding, these are all things that we want to provide, right? We want to individualize the care a little bit better, but we have to assess the baby, their response to our care, and their readiness for this care. So what are some of the things that we can do for clinical neuro exam? Basically, anything we can do for the baby, right? So this bedside exam, right? So just the head to toe exam that all of us were taught, probably differently, right? So all of us were taught by someone, some preceptor, to do a head to toe neuro exam. If you're a nurse practitioner or an advanced practice person, someone probably taught you to do it a little bit more detailed. But there are also amazing tools that we can use as well. And we're going to talk about a few of these tools. And so I think it's important to know that these tools are really designed to help us be more objective so that we could speak the same language, look for the same things, and maybe be able to watch a baby's response to care and to treatment and to their maturity really coming and happening in front of us. And so we have things like the SARNAT exam, which we use specifically for HIE babies, or the Thompson score, which is used for HIE babies. We have the NPAS score, so probably most of you are using NPAS. So pain, right? Isn't pain something that we assess every day? And it's really a neuro assessment. Things like NAS, feeding readiness, the NNS, the Dubowitz, these are all neuro exams that we have probably all used. And so in the class in Providence, we talked a little bit about the Dubowitz, and it was like when I first started in nursing 20-ish years ago, we used the Dubowitz all the time. It was a nursing tool. But I don't know when the last time any of you have done a Dubowitz. I know personally for myself, I haven't done it in years and years. And I see that even in the hospitals where I work, that they're not using it at the bedside at all. So clinical neuro exam, it's also complicated to do a neuro exam, right? There's a lot of issues with inter-rater reliability. There's inter-observer variance between them. And the other thing is our babies are sick, right? So our babies might be sick. Their babies might be immature, and they are sometimes very difficult to assess their neuro status. And even when we have our babies who are undergoing hypothermia, we have those babies who we also are trying to use this Sarnet scale on. It's hard to use these tools in certain situations, and yet we really do try to apply them across the board. The NPAS score, don't we try to all use it for our preemies, but we use it for encephalopathic babies. I feel like NPAS is just almost overused, and we probably need some newer tools, but validating these tools takes years. So we're really stuck, and we just have to understand it is one of the most powerful things we do, but it is super complicated. So what about some of the other ways we assess the babies? We assess the babies by doing CSF exams, so doing LPs and looking for inflammation or infection. The newborn screen, right? We do the newborn screen on every baby, probably in your state like in mine, and we're looking for metabolic disease. Well, why do we care about metabolic disease? Because babies who have metabolic disease that is untreated, remember, they used to show up in the ERs at a week of life, and they would be in either obtunded and comatose, or they'd be seizing and so acidotic and floppy. If we can prevent that, if we can diagnose it, we can prevent these babies and the injuries that would happen to their brain from that. So these are studies that we do every day in the NICU, and we don't maybe always think of them as neuro assessments. In the EU, they're doing things like visual evoked potential on babies, but here in the United States, we're all doing brainstem, auditory, evoked responses, right? So we probably all are doing hearing screenings, algos. That's a brain assessment. We do it every single day. So this age-appropriate assessments of babies. And so we want to make sure that we're assessing our baby's developmental state. We want to be sure that we're then providing interventions that are appropriate for their age. But babies send mixed cues, right? It's hard sometimes to know what exactly they're trying to tell us. So in the chat area, tell me, what is this baby saying to you? What kinds of things do you see this baby saying? What do you think? Yes, Kim says, stop. Yes, he's not giving high five to dad. Stop, stop. Yeah, and he looks like he's just laying there, but something is not quite right for him. What about his face? What's his face telling you? His eyes are open, his eyes are closed. Yeah, he's grimacing a little. Yeah, he's frowning. Yeah, he has got low tone and around his mouth. His eyes are closed. He's checked out. That's a perfect description. Just a lot of his whole forehead is very relaxed, but then you see this little bit of creasings right between the eyes. Yeah, checked out. His mouth is open, gaping open a little, so low tone in the mouth. Exactly. So although he would appear to just be resting quietly, if we don't pay attention to these little subtle signs, we might miss some of those. And of course, parents have a hard time reading these cues. We have to teach them, because preemies are different, and that they want them to be able to interact with their baby and to give them stimulus when the baby wants it. Great. Let's see here. What about this baby? What's this baby saying? So he's saying, feed me more, I'm so hungry. Is that what he's saying? Or is he saying, definitely stop. I'm finished. Yes, I'm finished. I'm done. Step back. Yes, step back. Stress signs. Yes, yawning, flaring fingers, panic attack. Oh my gosh, yeah. Yeah, so the yawning, the eyes closed. Exactly. So our babies tell us a lot, right? Every single day, they tell us a lot. And so we can know how to do their pacing of their cares. What about this baby? What's this baby saying? I love this baby. So eyes open, eyes bright. Lunch. That's right. Seems engaged. Yeah. This is a baby who, let's talk. I love that. Let's talk. So a baby who might want more. So you see how his hands are up at his face. They're closed. They're not fisted. They're closed, but they're up by their face, secure, ready to interact. Eyes open, soft face, mouthing, quiet, alert. Exactly. So these are all these things, these assessments that we do. And depending on all of you on this call, you've been doing this a long time. But we've got other providers in our midst every single day who don't know how to read these cues, who don't know how to pace babies. And so it makes our job sometimes even more complicated because we can just read these babies across the room. But others still need coaching and need training on how to help these babies and how to read these subtle cues. And of course, our parents, right? They need this all the time as well. Awesome. All right, so when we're thinking about assessment and trying to have some objective measures of this, so here's some things that we can look for. There's the NNS, the NICU Network Neurobehavioral Scale. You can go to Brown University there in Rhode Island, beautiful Rhode Island, and you can pay about $10,000 and you can get certified in the NNS. And so some units have sent a group of their staff to get this type of certification so that they can have a group of people who can help to evaluate in a consistent way the maturity of their babies and their tolerance to the environment. There are other tools like this one, the APIB, the Assessment of Preterm Infant Behavior. Understanding, and this is a great article where you can pull that you can understand and how it works, and it's both for term and for preterm babies. So it's another tool that you can use. Probably all of us on this call have heard of NIDCAP, right? Another very in-depth assessment of babies' competencies and helping us to evaluate their abilities and then allowing us to go from there and create a plan of care that's individualized to their needs, right? The neonatal individualized developmental plan for them. And that's really, we have to give Dr. Owls so much credit for kind of thinking about these tools that we could use to assess babies and to really communicate about what their strengths are and really how to intervene with them and how to create a plan that will help foster their development. And so these are very important pieces of a NeuroNICU program. Assessment, right? Because we really can't do anything until we've assessed where the baby is and where they need to go next and what their strengths are. One of my favorite assessments, and this brought a lot of discussion, and I actually moved it from the developmental section to this section, is the Infant Positioning Assessment Tool, or the IPAT tool. And I love this tool because I feel like it's one of these tools that is like a sleeper tool that very few people have used, except for probably some of you on this call. But it is a very easy to use quality improvement tool that honestly can make a big difference for your babies. And so the Infant Positioning Assessment Tool, or IPAT, it's basically, if you think of it like an APGAR score, there's a max score of 12, and it has scores from 0 to 2, and you look at 6 parts of the baby's body. So you look maybe at the head, and you're looking at midline head positioning. If the baby's head is midline, that's a 2. If the baby's head is turned, that's a 1. If the baby's head is all the way over to their shoulder, that's a 0. If their shoulders are retracted, that retraction is a 0. If they're neutral, it's a 1. If their shoulders are rounded, that's a 2. Same with hips. Hips out, that's a 0. Hips neutral, 1. Hips flexed and in, that's 2. So super easy. And some of the nurses who attended our workshop in Providence talked about how they had implemented this. And Sarah's saying that you're using this for a positioning improvement project right now. It's fantastic. And so we talked about NeuroNICUs can be just a quick QI project where you're saying, we think we can do one thing in our unit better. And so this IPAT tool, one of the groups talked about how they actually had their therapist, their PT, went around and they would do 5 random assessments every day. And they would just pick a couple babies and they would do it. And then they started doing education on proper positioning. And then they kept doing these audits of positioning. And they've shown a significant improvement month over month over month because they were actually measuring something. And I think that's the most important thing when it comes to quality, right? It's all about, you have to know where you are before you can move forward. And so measuring And using a tool can be one of these things. So either this can be a project that one person does and randomly does this, or it can be a full hospital implementation. So Sarah, tell us a little bit about how you're going to be using it for your positioning improvement project. You want to unmute yourself, or you can?
Yeah. Can you hear me?
Cool. Yeah, perfect.
Okay. Yeah. So we actually started this project in September. We had a webinar education that all the nurses did. And then we actually had a nurse educator come and do a hands-on positioning skills fair with everyone. So she had our positioning aids and practiced with the nurses one-on-one and in small groups, and then gave them a lecture just on the principles of good positioning and the effects of poor positioning, both short-term and long-term for the baby, so that the nurses really could understand what the importance of good positioning would be. And then she introduced the idea of this iPad tool to them. And before we did the education, myself and the other members of our project team did some pre-education audits so we could just see where our baseline was. And we are using, so the team consists of myself and a few other nurses, and then we have PTOT as well that's involved as my auditors. So then we did the education, and then we are now conducting the random iPad audits, and I shared our first month of data with the nurses. We have a daily huddle, so it's a good time to put out that information. So I just put it up on the huddle board, and it's just something so that they can see, here's where we were before, here's where we are now, and we're inching up towards that goal of we want to score consistently in the 10 to 12 range. And I have the data broken down by gestational age categories. I'm excited to see that we're making small improvements, and definitely people are more aware. And I've had more nurses come up and ask me, hey, can you help me position this baby? What am I doing wrong, or what am I doing right? What can I do better? So it definitely is, we've gotten positive response. And the iPad it's so easy to do the scoring. And I think that's part of where we've had a lot of success with it.
That's great. Love that. Anybody else using this or have any questions for Sarah on how they rolled it out? I think that's one of the most important things we can do, is to share projects and what people are doing. So if anybody wants to unmute themselves, if they have a question, or really about any of the tools that we've talked about so far. So how are you all doing? Doing good so far? I think I only have a couple more slides here just to talk about diagnosis-specific tools for that. So we talked a little bit about SARNOT in the very beginning of our neuro-assessment section. And I just wanted to just talk about the SARNOT exam. So the SARNOT exam was developed by a physician team family. I guess they were husband and wife, SARNOT and SARNET, in the 70s. That was a neonatal encephalopathy grading scale. And so the SARNOT exam has been adopted as a tool to help us rate encephalopathy, and then help us to identify babies who may be potentially helped by therapeutic hypothermia. So of course, we'll talk more about this next week, but this is just an overview of that exam and some of the criteria that make you normal or mild, have mild encephalopathy, moderate or severe. And of course, the moderate to severe babies are the babies that we are cooling. But the other thing I just really want to say about the SARNOT exam, and really all of these exams, is that these are dynamic exams. And babies change. They change from sometimes minute to minute, but hour to hour, and certainly from week to week. And we're talking about gestational age changes. When we think about examining our babies, we want to think about them serially. And there's some groups in San Diego that are actually training nurses to do these SARNOT exams. And for babies who have had a rough start and who are being considered for cooling but are not yet being cooled, they're teaching the nurses to do these exams at 1 hour, 3 hours, and 5 hours, and to pick up on subtle changes between the exams and potentially cool babies before that 6 hours in case there's any issues. This assessment is so critical to selecting babies, and as other therapies come available, we definitely want to be able to identify the babies who will benefit the most. And certainly having people who are doing the SARNOT exam is really important. Let's see here, there's more chat. Yes, those borderline babies. So I like to call those babies the maybe babies, the ones we maybe want to cool, but we're not quite sure. And so I think the maybe babies are definitely ones that need serial exams. So hourly, I think, is great. If they're sick or in an outlying facility, maybe every 2 hours. I know the San Diego group is doing 1 hour of life, 3 hours of life, and 5 hours of life. And that way, if they see a change, it's still early enough to be able to get transported to a local cooling facility, or they can begin passive cooling. And then the last tool I wanted to just mention is the neonatal abstinence scoring system and the Finnegan score, which I'm sure all of us have used and probably all of us have struggled with. But again, there's so much of this is really a neurological exam and really looking at the baby's response to treatment, the response to other needs that they have, and to the environment and to the meds they get. So neonatal abstinence scoring system. If you've not seen Karen Dappolito's training tool that you can actually purchase, which will help you to develop inter-rater reliability in your unit. So if your unit has a lot of neonatal abstinence babies, then you may want to invest in this inter-rater reliability training program. And it goes through each of the sections of the scoring tool. It then gives you some cases that you can actually watch a video of a baby being examined, and then you can score it, and then you can have a template to then score that against, and you have 2 or 3 different test babies that you can then work on so that people can have reliability. Because again, we're titrating medications, we're planning discharge and needs based on the score, and so we've got to do a better job, I think, sometimes of actually working towards this. And this goes for everything. So like you guys were just mentioning about the SARNet exam score, what are the things that you can do to improve reliability, create a core team, train them, test them, and those kinds of things. So I think it is very important that we pay attention to our inter-rater reliability on some of these tools. So just a couple little final things I want to talk about under assessment is imaging and the challenges that happen with imaging, right? So a lot of our babies need imaging, but they're very sick and it's difficult and challenging to get them off the unit. Maybe they're undergoing hypothermia, but certainly imaging is becoming more and more of a critical part of our day-to-day world. So what about sedation and MRI? So how many of you are actually sedating babies to take them down for MRI? Or what tools are you using to avoid sedation during MRI? What are you guys doing? Feed and swaddle, low dose IV or nasal Versed, papoose, yeah. Medvac immobilizers. I know, aren't those Medvacs so cool? Depends on the length and number of sequences. Yeah, it's hard, sometimes these long sequences. Feed and swaddle, then nasal Versed is usually the next step. Perfect. So avoiding IVs and all of that. Perfect. Yeah, totally, because it's so long. The sequences are so long. And if you haven't seen the papoose or the immobilizer before, I just wanted to show this papoose in case you hadn't seen it. It's basically a bean bag that you put a baby in and you wrap them up, and then you basically suck all the air out of the bean bag and it just immobilizes them right there. So feed and swaddle, put all of your equipment on ahead of time, your MRI compatible leads, your MRI compatible pulse ox, and giving all of the supports there. Feed, swaddle, and then take down to the scanner and timing your feedings just right. So if you haven't done this, is a great review in the 2008 Pediatric Radiology where they talk about unsedated MRI and doing nearly 1,000 babies at that point. And that was in 2008. They'd done almost 1,000 babies unsedated. And I just saw many of this team in Boston and they're still doing them, and they've moved this technique to other places. So it sounds like most of you are doing the same thing. Let's see. Now, what about other kinds of imaging standards? This was something that at the meeting in Boston last week, we talked a lot about. So when do you guys get your first cranial ultrasound? When do you follow up with the second? Are you getting term equivalent MRIs? What are you guys doing? Is it consistent? Do you have a standard? Or is it varying from place to place and provider to provider? What are you guys doing? Yes to all of it. First cranial ultrasound, 5 to 7 days. Okay, at least Jane and Katie, you're from the same hospital. You guys are doing the same thing. You guys are consistent. Kim's working on a guideline. It's great. Varies by provider. Yeah, generally first one is at 4 days of life or more, unless there's a concern. So it's interesting. So one of the speakers at this Boston meeting was Dr. Linda DeVries, and she's probably one of the most prominent neonatal neurologists and neonatologists, standardized for cooling kids too. Okay, cool. Yeah, so this is a great conversation. What she was saying, so Dr. DeVries is from the Netherlands, and she's saying that they're getting one on admission, a head ultrasound on admission, because they want to see whether or not the baby has a bleed on admission. So I thought that was interesting and different than what most of us are doing here in the States, where places I practice are like what all of you are saying, somewhere between maybe 3 after the 3rd day, right? Because what we'd say, oh, we know most bleeds happen in the first 3 days, so we want to see if they've happened. But again, we don't really know when they happen. So if we just say, oh, it happened in the last 3 days, but we don't know, maybe they had it when they were born. One of the other things I thought was very interesting. So if you start with that, whatever your protocol is to get the first one, and then maybe you follow up with a second, and then maybe a third later, and maybe you do one around 32 or 36 weeks again, maybe you do another to look for cystic changes and PVLs. One of the things that Dr. DeVries was really advocating for is if a baby gets septic, gets sick, has neck, you should start over as if they were just born. And we should re-image them, starting again, going for a few days and following up for a week. It was very interesting because she's saying that inflammatory process can actually cause this later PVL, later bleeds. And if we're not looking for it, we won't see it. And we won't know about it until we go to get that term MRI or that term ultrasound. I thought it was very interesting that she talked about that. So that when these kids get sick, do you start your scanning over? And I was like, ooh, places I work, we don't. We just get those kind of initial ones and then we go on. So MRIs are being done for discharge, prior to discharge for high-risk babies, but not sure of gestational cutoff, yeah. Definitely MRI is more sensitive than an ultrasound. And so some places are still getting ultrasounds and saying an ultrasound is still good enough, but what we really know is that MRIs are more sensitive. So it is definitely important to be getting those. But I think this is an area where, first off, you can start by standardizing in your own place, right? Start local. And then from there, you can start to look at some of the other international standards on this and some of the kind of changing thoughts, and then maybe see if you want to change practice. But I think starting with standardization in your own place and really thinking about why are we getting the images when we're getting them. Europe is a little different, right? In Europe, many of the neonatologists do the scans themselves, and so it's really a point of care kind of test. It's not as much of a burden bringing in our techs like we have here in the States. So there's a lot of challenges to neuroassessment, right? First off, we have varying skills. Our babies oftentimes have sedation. Our babies might be small, so there's gestational differences. And there's just so many different scales and tools to use. But it is certainly not impossible. It is certainly possible to do a very thorough and a very structured exam and to get better at it all the time.
I hope you enjoyed the first part of our series today. We went into the what, the why, the how, and as well as we dove into deeply some of the ways that we assess our baby's neurological status. We use tools, we use different techniques, and in the end, it's about trying to create a common language around what we see and what we now can do to intervene to improve that baby's outcome. So again, this is the first part of this series, and stay tuned for next week when we will dive into my favorite topic, neuromonitoring. We will talk a little bit more about aEEG. We will talk a little bit more about NIRS and other ways that we can monitor babies at the bedside. And don't forget to claim your free CEUs and to download the workbook by just clicking either in the show notes, the link that is there, or right here on the screen, scan the QR code. All right. Hope you have a